what we were talking about at the meeting and now the virtual meeting, sorry not to be there in person, is progress that's been made since FDA approval with cell therapy for ALL. That was the first FDA approval for kids and young adults up to age 25. And that's still the current only FDA approved therapy, cell therapy for ALL. There are others in development, but that's what's approved by the FDA. I think there's been a lot of interest in the issue of toxicity control. That has gotten considerably better in the years since the registration trial and the FDA approval. And you can see that in the real world data where the risk of more significant CRS, grade 3 and 4, generally that puts you in the intensive care unit, is down from almost half of the patients on the registration trial for Kymriah or Tisagenlecleucel to 16% now. And we've seen the same thing in our own hospital, going from 40% ICU admission rates down to 12% at our hospital over the 400 patients that we treated. So I think that seeing that improvement, I think is great. We have just reported on a study where we are giving prophylactic or rather preemptive tocilizumab, and the circumstances are high disease burden, over 40% blasts. As soon as the patient gets a fever, single dose of toci, and has seen that significantly decrease, but not completely remove the risk of grade 4 CRS. So that seems to work without increasing ICANS in using the cell therapy product Tisagenlecleucel. And I think that the final issue that we're sort of looking at is the issue of how to deal with the relapse risk where the ALL loses CD19, the target for CTLA-19 or Tisagenlecleucel or Kymriah. And if that happens, is there something we can do? We can treat these patients with a CD22 CAR, but we'd really like to prevent that CD19 escape. And there are a number of studies underway trying to address that issue.